All right. Hello, everybody. Welcome to another episode of Digital Health on Air. My name is Tashmin Akram. I'm the Chief Medical Officer here at Luma Health, and we have a real treat for you today. We are joined by Dr. Tina Shah, who is a Chief Clinical Officer at Abridge. She has an extensive background working in probably all facets of healthcare, which is really interesting because most physicians don't actually get to do that. She started off her career, and she will give a much better justice to her background. But let me just give you a 30-second spiel on her because her background is pretty widespread, which is hard to do as a physician. She started off as a traditional physician, working as a physician, and then she worked at large healthcare systems, getting experience working in large organizations. She even spent her time working with the government, which is fun and also challenging. And then now she's working on the commercial side, working at Abridge. But with that, I'd love to have her just give a quick spiel about her journey through her career.
Tashmin, thank you, and it's great to be here on the podcast. Well, I guess I have to start with what's most important, which is my specialty, which is I'm a pulmonary and critical care doc, and I'm actually going to be on service for a Labor Day holiday, so I'm kind of gearing up for that. And I think I would definitely say I'm a non-traditional doc, and most of my story is fueled by really wanting to do medicine for all the usual reasons that doctors and others do, and then getting burnt out. So yeah, you said it right. I have worked in large health systems. I was an acting chief medical information officer in the early part of the pandemic at a system called Wellstar. I was privileged to be in the government a few times. So my first time, I actually served under the Obama and the Trump administrations and had a dual appointment where I was VA's first director of clinician well-being. You can see there's a theme here. I was basically trying to hope that this would never happen to anyone else after I got burned out. Have done private consulting, and now I'm privileged to be part of a generative AI company that's trying to solve for burnout.
No, I think I remember when I went through med school, there was always this. Well, people always talked about the non-traditional route, i.e. like doing other things, and it was always hard. But I commend you on it that you have found your path in many different ways. But as you said, there is a consistent theme here, which I think this is what I'd like to really pick your brain on. So I think any physician who's been working for more than a year or something in the medical world knows that physician workload is high and expectations are high. But we've been talking about this for years, the term physician burnout. I'm not sure when it first came into being, but it must have been like 10, 15 years ago. And we've tried to do a lot of stuff around it. So I think maybe what would be great is if you could maybe just kind of walk us through where, how this started, what we tried to do, where it's going, and particularly maybe focusing on personally, I think it's getting worse. But I think, I'd like your perspective on it, just the, grand scheme of what's going on in the physician burnout kind of world.
Yeah, and I got to take us back to the 1970s. That, okay. I think is when it started, but I sure didn't know that. Did you? So the first thing that happened in the 70s is there was the first validated tool to try and understand burnout for healthcare workers. It's called the Maslach Burnout Inventory, or the MBI. And that gets created. But if in the 1970s by Christina Maslach, a PhD, a psychologist, I believe, when we fast forward then and get to kind of where we are now, I'm with you. It doesn't seem like burnout was really discussed if we go 20 years back. It's really started to ramp up. I would say even 5 years before COVID is when we really started hearing about it. But I don't know if you're like me. No, I spent some time trying to really get to understand burnout. It is a occupational condition. It's literally caused by the toxic workplace that we have in U.S. healthcare. But also, it's not just the U.S., right? It's across the globe. And because of that, I think on one hand, you would say there shouldn't be stigma. If more than 50% of U.S. physicians are burnt out, it's clearly not a me thing, it's a we thing. But somehow we've super stigmatized it. And I would say now, coming off the heels of COVID, it feels like people are acknowledging it and then moving on versus spending time on what really the drivers are. So I think if I really look at how the conversation has evolved since maybe 22, when we were starting to round the corner of the pandemic, we haven't quite gotten to, well, how do you even measure physician workload? Because if I had to keep it simple, burnout is a occupational state. It's when you think about work, your feelings about work, and it's when the job load outweighs the job resources. That's it. I mean, there are other more technical definitions, but this one really resonates with me. And I think, we haven't quite well documented what our workloads are. We start thinking about documentation burden. We start measuring pajama time. That still doesn't fully encapsulate how hard is it, right? There's the emotional work, the mental work. You could have the same number of hours and be completely exhausted and other days be fine. So I think we're really in an interesting position where it's something like we're losing about 10% of the U.S. physician workforce. I mean, I'm trying to remember, in 2021, that's how many people we lost, close to 100,000 doctors. On the nursing side, the nursing pipeline is fine. We're graduating enough nurses, but more nurses are leaving than staying. So we still have, we're only going to worsen the nursing shortage. And on top of that, we have clearly an aging population. So we're about to get into, I don't know how we can't say we aren't in a firestorm now, but the firestorm's going to get bigger. All of us on the front lines, you and I both know that it's really hard to doctor right now and to serve our patients, but it's only going to get worse because there seems to be some apathy, and it actually shocks me a little bit. And I'll just say this. We know exactly what burnout is. We have a definition, and I gave you a rough one, which is when the job demands outweigh the resources. We actually have evidence-based interventions, and we know they work. So there's published data on that. But it's interesting, the change management required to implement these things are so great that we don't exactly succeed. And I don't know, I'm just going to end with one thing. One of the biggest drivers of burnout, and this one's going to be really hard to touch, but when you have a supervisor, a boss that doesn't have the full managerial capacity to help you thrive, or when we feel like we have a loss of input, that's like one of the biggest drivers of burnout. And you can understand why change management is so hard, to change how people lead, how they manage. But I'm very curious, and I'm sure you're going to lead me here. There's something about technology. I mean, can we conceive a world in which tech works for the humans and takes away some of our pain and not the other way around?
Yeah, and I think what's really interesting is that with all this AI advent, I was just recently at a user conference for an EHR, and like one of the things that someone who's in the managerial position would mention is that, like, all the physicians are coming to us and saying, can AI solve this? It's in our back of our minds. And it's interesting because I think you being in technology, and I think a lot of others who have been in technology, sometimes technology can be overpitched, particularly AI has been a little bit overpitched. But of all the different things that I heard at the user conference, I want to say that there's optimism more than just, but I feel like there was a good amount of optimism in solving this issue, i.e. provider burnout. And so I want to explore that more with you. Now, one of the things that there was, and I'll lead you in this a little bit, and then we'll let you delve into, because this is obviously your expertise. One of the things the user conference talked about was like the patient side of stuff. So providers are having to spend time messaging patients, whether it's portals or whatever it is. So there was a good amount of focus on trying to figure out, does that help on the burnout side? But I think there's another part of it that we've been trying to solve for years, and perhaps, and I think a lot of physicians know EMR is kind of is the double-edged sword. It was supposed to solve a lot of problems, but at the same time, it created a lot of problems, which I think any physician could kind of appreciate. But I with the optimism bent on, how can AI solve provider burnout?
Yeah. And by the way, I have to take us back just one more step, because I forgot to mention this earlier, but the American Medical Association, for the first time this year in 2024, said that the burnout rate has dropped amongst physicians. And so on one side, you're like, are we doing better? Is burnout really that bad? But on the other hand, many people, myself included, believe that we have lost so many people that have been burnt out that perhaps we're not accurately capturing the burnout rate. So I think we're actually in a even more dangerous scenario, which is where I'm really excited about AI. And I would also say that what's great and almost feels like a no-brainer, but we need even more data to back this up. The research shows, but even if you talk to your partners, right? Patients and clinicians tend to have many of the same pain points. If you were to follow a patient getting checked in at their appointment, getting roomed, getting their vitals, seeing the doctor, then getting the blood work, finally checking out, all the things involved, and then getting called back for that prior authorization, whether that MRI went through or not, and you map the doctor's journey, it's nearly identical. We have the same pain points. So there's something special there in thinking about the intersection. There's something about allowing humans to have more time with humans. And I think that's what AI is doing. So for me, I'm taking maybe I'm feeling philosophical today, but I want to take this point of, can we return humanism back to medicine? And my answer is, I think AI has massive potential to do that, to where if we take this tool and put it in the right direction and really focus on something that is deceptively basic and simple, help people focus on each other and have conversation, I believe the metrics of burnout will improve. Like, that is an end state. I also believe the metrics of patient experience and good patient outcomes also improve. And even potentially cost is improved as far as how much we spend, nationally on U.S. healthcare. But if I were to distill it down, I want to go back to where you started with AI, which was about responding to patients. And there were 2 papers published recently, and I think it was on Epic's tool called ART, which is an AI-generated response to patient in-basket messages. And there is more research needed, clearly, but these first 2 early take papers published in high-quality journals said something to the gist of, doesn't change the time the doctor or the APP is spending, but sure does reduce cognitive load. And I think that makes sense. It is much easier for me to edit something that I've been given versus create it for the first time. And over time, I think that is going to manifest. That particular technology that is sort of geared towards responding to patients, but is a tool for clinicians, is going to help us. And is it okay if I actually go into a little detail with cognitive load? Because I think
go for it, please.
Okay. I mean, I think we all generally understand burnout. It's sort of like you're out the point of no return. You try and take a vacation, but you come back to the same place, and you need dramatic changes. Like, I need to hire more MAs or LPNs to really make things different. I need less work. Otherwise, I'm going to be in the same situation again. That's burnout. And we have surveys that can measure it, the degree of it, and they're validated. But there's an intermediate metric called cognitive load, which is literally the amount of working memory you have and have you exceeded it. And that has a validated survey that you can measure too. And there are papers that show that this validated tool called the NASA Task Load Index is directly linked to the odds of burning out and the odds of making a medical mistake on a patient. So lately, I've been thinking more about AI's potential to reduce cognitive load, and it's almost upstream of that situation of burnout. So that's why I wanted to just define it a little bit for us. And I'll tell you, at Abridge, where we have a different product, we are using ambient AI to help with another one of the top contributors of burnout, which is just SOAP note documentation, making the medical note documentation. And we're seeing crazy reductions in cognitive load, somewhere in the order of 40 to 80% reduced cognitive load before using ambient AI and after. So I'm really, really excited because as a burnout expert, I've never seen any intervention with the needle like this.
No, yeah, and I think it's very interesting that when you're talking about this cognitive load and physician burnout, I think the other story and you mentioned it very well, is that you forget about the patient impact. Actually, maybe we of course, people understand, better physicians, better patients, but I think what would be really interesting as we get further down into this is that looking at what outcomes actually, ultimately, are there better patient outcomes? And in theory, it's the logical assumption that if you have a physician who is better equipped to be able to treat you, then the outpatient outcomes, we actually don't talk about that at all, which is really interesting because it's very difficult to actually capture because obviously patient outcomes are different between patients, But in general, I mean, I think it's very interesting topic because I think that's one thing that we probably don't look at all. And it's also interesting. Also, just one more, and you mentioned that paper on art. So it reduced cognitive load. So art, for those who might not know, it's called automated response technology. It's something, I think it's a term that maybe Epic has coined. I'm not 100% sure, but what was also interesting about that was that they looked at patient satisfaction, and patients found responses that were generated by generative AI to be more pleasing to them than physician ones, and that sort of makes sense. But I think what you're saying is like this. So by addressing physician burnout, it's actually kind of a holistic solution. It's not only just helping physicians be better physicians, it's actually helping the healthcare system work better in treating the patient. And I really like that framing of returning the human, into the human focus into the equation of healthcare, because ultimately, that's what we're in it for.
Oh, totally. And I got to tell you, Tashfeen, we're asking a question to clinicians as they're using our technology on distracted doctoring. It's essentially a question that says, how present do you feel with your patients? And stay tuned. We're planning on analyzing our data for a multi-center study on clinician experience with ambient AI. It should come out later this year. But we're seeing something like 30 to 40% more physicians and APPs say that I am more present with my patient. So, I mean, perhaps if I was present, I would write a nicer message back to my patient. I'm just speaking about myself, so I know I can rag on myself. But there's something about when you have just so much work to do, you aren't as thoughtful. Also, you miss cues. So I think there's something, I can't wait for the day that we have a metric for distracted doctoring. Right now, I feel like if you go to those patient experience surveys, like let's say Press Gady, they have these questions on something to the gist of, did my doctor look into my eyes, right? Did they make eye contact? Did they listen to me? And those are good proxies. So is our question that we ask clinicians on, do you feel present? But I can't wait till we have a crystallized metric to talk about what we innately know. Because if we could measure that, I'm pretty sure that is linked to better patient outcomes, more presence, lower costs. Maybe we aren't ordering six CAT scans because they went to different health systems. We can kind of piece it together and go from there. But when I think about AI's opportunity, I'm feeling this as a doctor on the front lines. I use ambient AI in my practice, and I'll just share at the extreme. I practice in the ICU, where as soon as you get in, it's a race to how many patients can you see before someone goes into a cardiac arrest, right? And you have to run and you get distracted. Also, while you're talking about one patient, but the entire team, including the nurse and your residents, someone else is active, and another nurse comes up and has something urgent to tell you about a different patient. So we're constantly being pulled around. And now when I'm using Abridge as an example, it is recording the entire conversation. It somehow is able to parse out the distractions. And I leave the end of rounds having a perfect memory of what we discussed and what the care plan was. And when I finally sit down to write my notes, and we're talking not right after I round, we're talking maybe after dinner when lots of things had happened, I have a perfect memory, and it makes me feel, and I'm going to say, I know that I'm doctoring better because I feel like I'm dropping less balls. I'm having less delays because we're doing it in a more timely manner for whatever we decided to do.
No, I think there's a lot of potential. So as you talked about, AI has lots of roles, and it's becoming quite exciting. And I think physician burnout, but I'd like to get your take on, and as we're kind of closing out, as healthcare systems look to implement AI, and then they're looking at technology to help providers, or it could be even other, AI technology. They might not be particularly focused on provider centric workflows. What recommendations do you have in them? Because when I was at this user group meeting, there was still a lot of excitement about AI, but you could tell there was hesitance because I think certain companies, I didn't mention names, but companies came out, made a lot of big promises, and then whether it was on ROIs or what they could accomplish. And, some of them didn't live up to it. So there is a little bit of reticence on not even just providers, but healthcare systems on, can AI companies or can AI technology deliver what we promised on? And so for for our listeners who are coming from the healthcare side or from the purchasing side, or who are trying to evaluate AI solutions, I'd love your take, because at Abridge, you were obviously worked with a lot of healthcare systems. You had to jump that hurdle of helping them understand, like, maybe there's no hard ROI here, but you know what, this is what you guys need. So I'd love what advice do you have for our listeners who are coming from the healthcare system side when they're looking at evaluating AI technology? What can you give to them?
Wow, and that's the last question you're asking me? Woo!
Yeah.
It's a lot of pressure. It's a lot of pressure. I think I'm going to leave with maybe three main points. Their first point is try it and fail fast. Because you could take the perspective of, I'm going to wait. We're not an early adopter organization. We're running on razor thin margins. We just can't afford it. But you're underestimating that it's around $500,000 to $1 million every time you lose a physician to burnout.
Wow.
So, and I know you didn't quite ask about just AI only for physicians, but there is an opportunity cost that's not quite on the P&L statement. And so my recommendation would be use AI for a low stakes use case, somewhere, some place like clerical work, whether it's for the front desk staff or your physician or somewhere else, and try it and fail fast and learn and move on. Because this is going to be like the pencil when we first started, or the pen when we first started with handwriting notes. It is going to be integrated into our healthcare system and how we practice. The second thing I would say is, I think you should expect your AI vendors to prove it. And I'm saying this as a vendor, but I think I'm remembering the time where I was on the purchasing side, and we've been sold so many shiny new objects, but the stakes are way too high to just go off of a case study or a referral. There are validated tools to measure what I'm going to call real ROI, as in my opinion, beyond financial ROI. But we should think about how we need to look at patient and clinician experience. There's a way you can measure burnout. Why don't you ask them, have you used validated tools? There's a way to measure cognitive load. You should ask them, can you show me your data on what you did with cognitive load? And these are things that can happen in a matter of 30 days. We're not talking about studies that take 6 months because of how what AI is typically being used for present day. So show me the evidence. And I think the last thing I would say is focus on the transparency, because there is a lot of concern about AI coming into our clinical workspace and it hurting somebody. I think the stakes are way too high. So I think it's an appropriate question to say, help me understand, without being a computer scientist, how does your technology work? And help me look underneath the hood. That's been the approach at my company. In fact, we have a way that clinicians we think trust is table stakes. We think transparency is table stakes. So we have a way for a clinician to look at any of the AI that was drafted in their SOAP note, highlight a piece and see exactly where it comes in the transcript. So that doesn't overload them. It doesn't require them to be a computer science expert, but they can still see it. So I think those three things would be foundational to trying to bring technology in, particularly AI.
Well, Tina, I really appreciate your time. And trust is definitely something that I think for some of the early AI adopters, maybe in some of the healthcare systems, lost a little bit of that trust. But I hope your work at Abridge will kind of help us as a community of AI vendors win that trust back. But I really appreciate your advice and your insight. This has been a true pleasure. And hopefully, we should have you back, because I'm sure we can pick your brain about lots of other things.
Oh, it'd be my pleasure. Thanks for having me today.
Yeah, thank you so much.